So I've been asked to introduce our next speaker, Dr. David Simpson. He's going to be appearing virtually from us. I can see him if you guys can see him too. He's a professor of neurology at Icahn School of Medicine at Mount Sinai and director of the Neurophysiologic Laboratories. He got his MD degree from SUNY at Buffalo, internship at Cleveland, Case Western Reserve, residency at Cornell, fellowship at Mass General. So he's been over many good places, author of 246 original peer-reviewed publications. His interests include treatment of neuropathic pain, HIV/AIDS complications, including spasticity, limb dystonia, and tremor. He received the Mitchell Max Award for Neuropathic Pain from the American Academy of Neurology in 2018 for outstanding achievements in management of neuropathic pain. He joins us today remotely. Please help us welcome Dr. Simpson.
Well, hello, everybody. I'm coming to you from New York City, where I'm based. I'm sorry that I can't be with you there in person, but I hope I'm coming through loud and clear and talking to you from the comfort of my home office, maybe next time in person. I was a bit of a late addition to the program, but I'm more than happy to be with you today. Now, as you heard, I am a neurologist. I know that some of my colleagues are there in the audience. There's also quite a number of psychiatrists, I understand, and some nurse practitioners. And so we have a bit of a varied audience, and it's always a challenge to try and present a topic to an audience of varied backgrounds and interests. And so, of course, I'm going to do my best to make this relevant and interesting to all of you. Now, when we were talking about topics I might talk about, you heard a little bit about my background in neurologic complications of HIV and AIDS, including dementia, in peripheral neuropathy and neuropathic pain. And one area that I'll focus on today is spasticity. And my particular interest in spasticity has focused on treatment approaches, including the use of botulinum toxin. And so I'll hope that some of this is of interest to many of you, and we'll certainly have time for questions later. Now, if we go to the next slide, you see my disclosures. I research and have clinical trial grants from several of the companies that you see here working with botulinum toxin. Moving to the learning objectives, I'll talk a bit about spasticity and the clinical presentations. Then the next slide, we'll discuss how to individualize treatment for the given patient, because every patient with spasticity has their own set of issues and their own set of goals, and therefore treatment really does need to be specific to each patient, and we'll talk about what the options might be. Now, moving to the next slide, I'll speak a bit about the definition of spasticity, because it's not always so straightforward, the associated features beyond just muscle tone, what diseases cause spasticity, how we assess the patient, how we set goals and expectations of treatment, something that's often overlooked, the treatment options, and then talk a bit about one of my areas of interest, botulinum toxin. Next slide. Now, if we go back to a classical definition of spasticity, Jim Lance and others going back years, it's fairly specific. It is a motor disorder with a velocity-dependent increase in reflex. And we often term that an increase of muscle tone, stiffness, or tightness of muscle. This is one component of the broader syndrome of the upper motor neuron syndrome. Next slide. Now, what happens when we damage the brain or the CNS? Well, a couple of things happen. And to simplify, as we look on this particular diagram, on the left side, we see a loss of connectivity to the motor neurons. We lose muscle activity. What happens? Weakness, fatigue, loss of coordination, loss of sensation. These are what you might call negative symptoms, loss of motor control and sensory control. But there's an interesting flip side on the right, which is loss of inhibition of the motor neuron, where we end up with muscle overactivity, or positive symptoms, spasticity, increased reflexes, clonus. And these muscle overactivity symptoms, we do have potentially good treatments for. Next slide. Now, in addition to problems of muscle tone that we see with stroke and spinal cord injury, we see a lot of consequences of spasticity, starting from the top left: loss of motor skills, contracture, which is fixed motor joint problems, pain, of course, restriction in mobility, and reliance on caregivers, and a major financial burden in patients with chronic spasticity. Next slide. Now, of course, there's a wide range of diseases of the nervous system that result in spasticity. And these are probably underestimates, but of course, stroke, a major public health problem, traumatic brain injury, cerebral palsy, multiple sclerosis, spinal cord injury, all of these disorders result in significant numbers of patients affected with chronic spasticity. Next slide. Now, when we think of patients and we see the patient in front of us, we can begin to break the body down into joints and regions, and we can see that particular parts of the body are affected with spasticity. And you see here, for example, the shoulder, the wrist, the forearm, the clenched fist, elbow flexion, thumb and palm. And we can treat these globally with various approaches, or we can treat them locally with agents like botulinum toxin or Botox, and we'll talk about that. Next slide. Now, if we move to the lower limb, again, we see a wide range of potential problems. The classic equinovarus gait, people walking on their toes or sides of their feet, a striatal toe, knee extension, knee flexion, adducted thighs. Again, you could begin to think that if you're thinking of localized treatment, you can address each of these deformities with the individual muscles affecting them. Next slide. Now, one of the big questions in any disease, particularly neurologic disease, that we have to ask is, what is meaningful function? And by that I mean, how do we decide what we're trying to do to make a patient better? And we can talk about two types of function. We have active function on the left and passive function on the right. Active function are things that the patient does for themselves. Reaching, grasping, releasing, walking. These are high-level activities. Passive function on the right is what we do for the patient or doesn't require the patient's voluntary action. Range of motion, position, hygiene, spasms, fitting orthotics, pain control. Now, as I'll show you soon, many of the trials of drugs have shown we can improve passive function, much more difficult to improve active function. Next slide. Now, here are a couple of examples of what passive and active function might look like. On the left side, before treatment with Botox, you see a patient with a clenched fist deformity. For example, many patients in the nursing home with Alzheimer's or chronic stroke or brain injury have this clenched tight fist. And it's very painful. It can cause malodorous palm infection and so forth. And after a bit of Botox is put into some of the arm muscles, here for the finger flexors, now you can passively open those fingers much more easily. Not that the patient is using the hand voluntarily, but you can passively get the fingers open. And that could be an improvement in passive function for this patient. Next slide. Now here's a very different type of deformity. And here we have on the left picture, a patient with a contracted flexed digit. That is, digit 2 is bent under the soda can after a very small lacunar stroke. Now you can imagine if any of you have a coffee cup or a can in front of you, if that finger was flexed, that makes it rather difficult to manipulate objects. Now here, with a very selective use of botulinum toxin into digit 2, the patient is now able to extend that finger around the can and to have voluntary use of that hand much more easily. And for some reason, the patient switched from Pepsi to Coke. I don't know why. I have no proprietary interest in either company, but suffice it to say, they're better. I don't know if the soda's better. Next slide. Now here, of course, is mobility and gait disorder. Here's a patient with a stroke who you see from the front and the side, and on the top, they have this classic equinovarus gait, walking on the front and the side of their foot, very painful and uncomfortable and difficult. Here again, with some strategic use of botulinum toxin to some of the calf muscles, you see the patient returning to a very nice flat foot strike. Next slide. So what are some of the goals we're looking for when we treat a patient with spasticity? Well, we're trying to relieve symptoms, pain, spasms, position, ease caregiver burden, including dressing and hygiene and positioning and transfers, patient active function, reaching, grasping, and even facilitating PT and other long-term goals. Next slide. Now, what are the options we have for treatment? Well, one important point is just because a person has spasticity, it doesn't mean you must treat it unless it's causing disabling symptoms. And some of the treatment options, as you see here, include PT, OT, various pharmacotherapy, oral medications. I won't speak about a lot, but they include things like baclofen, tizanidine, and even intrathecal baclofen in some patients. There are surgical approaches, and I'll focus for the rest of the talk on botulinum toxin. Next slide. Now, the history of botulinum toxin is a fascinating story and has essentially permeated every area of medicine, certainly neurology, and is beginning to penetrate psychiatry as well, which I'll talk about a little bit later in brief. But going back to the early 1700s when the bacteria was isolated, into the 1940s when the US Department of Defense did research on it, the molecule was purified in the 60s, and then probably Alan Scott is credited as using the first medical use in eye disorders. Next slide. Now, what are some of the uses of botulinum toxin that have emerged over the years? Well, here you see a short list and partial, including neuromuscular uses, things like strabismus and spasticity, both adult and children, blepharospasms, cervical dystonia, and most of our patients in the public arena think of it for cosmetic uses like wrinkles. There are autonomic disorders like achalasia or esophageal spasm. Hyperhidrosis, excess sweating is an FDA-approved use. Sensory uses now, it's FDA-approved for chronic migraine, neurogenic bladder, and even some interesting use in painful neuropathy. Next slide. Now, there was an interesting Time magazine cover in the last couple of years, and remarkably, they indicated there were potentially 793 different disorders that Botox or botulinum toxin has been reported to be useful for. I don't know where they came up with that number. That is pretty high. But notice the first item on their list here is depression. So for the many psychiatrists in the room, you may have heard a bit about the emerging data of the use of botulinum toxin or Botox into the facial and forehead muscles for relief of depression with very intriguing early data, of course, by no means yet FDA approved, and many other interesting uses. Next slide. Now, for those of you using botulinum toxins, it's important to know that there are several of them on the market. And I'll use the brand names, which you're probably more familiar with. There are type A serotype, Botox, Dysport, Xeomin, Doxy under development, a type B called Myoblock. And these are different drugs, different molecular formulation, and different side effects. Next slide. Now, as far as FDA-approved indications, I'm not going to go through these in great detail, but on the top you see the 4 different US toxins available. And then we see on the left some of the different indications that it is approved for: cervical dystonia, upper limb spasticity, lower limb spasticity, and several others. I'm not going to talk about all these today. Next slide. Now, how do we know in medicine what works? I know you just had a talk on sleep and drugs for sleep efficacy. And in fact, these principles transcend all of medicine: efficacy, safety and tolerability, ease of use, cost and access. Next slide. Now, a number of years ago, I had the opportunity of leading a task force for the American Academy of Neurology, and we produced evidence-based guidelines based on a review of the best medical literature for the use of the various forms of botulinum toxin. We did a series of papers in 2008, then in 2016 updated several of the disorders, as you see here, including spasticity. Next slide. Now, based on those evidence-based reviews on the best literature, we were able to divide the different toxins into the level of evidence supporting their efficacy, with level A being the highest, level B next highest, C, and so forth. And you can see for the various disorders, if we look, for example, at upper limb spasticity, you see that 3 of the available toxins have level A support for efficacy. And in lower limb spasticity, we see 2 of the forms with level A evidence. Next slide. And here again, we have adult spasticity in the upper limb, level A for Dysport, Botox, and Xeomin. Level B, probably effective, Myoblock. But notice that even these placebo-controlled studies showed only passive functional gain rather than active. Next slide. Next slide, please. Now we look at the lower limb, and here 2 of the toxins had level A support, Dysport and Botox, with insufficient evidence for INCO being Xeomin and Myoblock. Again, passive gain in tone, but not active gain. And if there are questions, we can talk a little bit more in detail about what this all means. Next slide. Now, one of the big challenges in medicine in general are the systems we work in. Let's take a stroke patient. And you start at the top, they have an acute stroke, go into the ICU, step down into another hospital unit, maybe get discharged into rehab, then to a home or nursing home. And notice that as they get into long-term chronic care, managed by a GP, maybe a nurse in the nursing home, a physical therapist, the level of sophistication of the management of spasticity is not quite as high, and therefore it's not surprising that many of these chronic patients are not getting access to the state-of-the-art care, including the botulinum toxins. Next slide. Now, one of the challenges in medicine in general is how do we compare drugs? For example, botulinum toxin versus tizanidine, oral drug. Do we know whether one is better than the other? And really the only way to accurately know this answer is doing head-to-head trials. So in this particular study of Botox versus oral tizanidine or Zanaflex, we use double injection and double placebo to accurately compare the results. Next slide. And let's skip to the next slide because I'm going to move along. And what you see here is the reduction in muscle tone. In red, we have placebo. Down is reduction in tone is better. Notice black, the botulinum toxin or Botox had a significant reduction in tone, better than placebo, but tizanidine actually did worse than placebo. Why is that? Because the doses couldn't get high enough because most of the patients had side effects. Next slide. And here, when you look at the tone at the finger flexors, we see even more dramatic similar results. Next slide. And why is that? If we look at the adverse effects in the tizanidine arm in the middle, over 90% of patients had sedation and dizziness, which limited our ability to escalate this oral drug. Next slide. So move to the next slide. I've already gone through the conclusions. So again, for sake of time, I'm going to skip over end play targeting. So let's move along. And if there are questions about, let's stop here for a moment. I'm sorry to skip a couple of slides, but I want to stay on time. Now, for those of you using botulinum toxin, one of the interesting questions over the years has been, does one develop antibodies and loss of response? And for years, it was thought this wasn't a big problem, but there was a recent paper from Albrecht in Germany that showed that particularly in spasticity, if you look at the top left graph, that green section in spasticity, there was still a significant rate of antibody formation. And therefore, we really need to still consider the possibility that this drug may be causing antibodies, and we need more information about this. Next slide. So what are the open questions we have with botulinum toxin therapy? How do we inject? How do we know to get the muscle exactly where the needle should be? And there's different ways of doing this that we can talk about later if you like. What is the best dose to use? How many injection sites per muscle? What are the true differences in these different toxins? Can we inject earlier than every 3 months? What about antibodies? And as I travel around the world and speak in other countries about this, one of the big challenges is this is an expensive drug, and given insurance and governmental coverage, many patients just don't have access to this very valuable medication. Next slide. Now, one of the last points I'd like to make before finishing up is something that, again, is a principle that transcends all of medicine, but is particularly notable in botulinum toxin. And that is, do patients know what to expect? Do they know what the treatment we're giving them is really supposed to do? And this gentleman that you're about to see is a patient of mine. He was a major executive in New York City who had a major stroke. And this is his story of his first experience from another doctor with Botox for strokes and spasticity. Let's play it. Amplify one comment you just made about when you first got treatment, you were looking for a miracle and you thought you were being cured. Did you find that when that didn't happen, were you disappointed?
Yeah.
You were?
I mean, yeah.
Did you ever think of not continuing with treatment because it didn't do what you had hoped it would do?
I went a few years without another injection.
You did?
Yeah.
So he went for years because the treatment didn't cure him. Of course, we certainly didn't expect a cure. That wasn't a reasonable expectation, but this is what he was hoping for since no one told him otherwise. Next slide. And so what I often like to finish with is this cartoon, which reminds me about the use of botulinum toxin, having worked in it for decades, is the patient saying the following. Well, this is a rat in a bed talking to a patient. And the rat is saying the following. I go home today. They cured me using this new miracle drug. I'm afraid it'll be years before it's approved in humans. And in many ways, that mirrors our experience with botulinum toxin, using it for so many new indications, including, frankly, depression. And of course, who knows if and when it will ever be approved. Next slide. And so what are some of the SMART goals that we can hopefully leave everybody with? It is to recognize the causes and presentations of spasticity in your patients, the impact on their quality of life, partnering with patients to develop individualized treatment plan with clear communication on what are the goals, what are the quality of life issues that we're looking to improve. Next slide. And I'd like to acknowledge some of my colleagues that I work with in Mount Sinai who have helped me with much of this research and clinical work. My research team on the left, neurologists on the right, rehabilitation medicine doctors, and there's no question that this is an interdisciplinary approach that requires a team. And I think that might be my last slide, and I'm more than happy to open it up to Q&A. And I'd also remind you all to fill out your evaluations. And so I have a little chat box in front of me, and I'm getting a couple of questions that are emerging, and hopefully we'll get some more. So please feel free to provide the questions to the moderators. And here are a couple of questions that have come up, and let me see if I can repeat the question and then try to provide an answer. So coming from reverse, can I expand on the topic of antibodies and the use of botulinum toxin? And I'll apologize up front because I know I really flew through some of these major issues that could each be an entire lecture in itself. But let me say another word about antibodies because it is gathering a lot of attention. Botulinum toxin is obviously a foreign protein. And when we inject foreign proteins into the body, we may develop immune response. And one of the consequences of that immune response is the creation of antibodies. Now, when we create antibodies against a foreign protein, the antibodies may be directed against the neurotoxic component of the molecule or non-neurotoxic component, the so-called carrier proteins. If one develops antibodies to the critical neurotoxic part of botulinum toxin, that is the part of the molecule that's actually doing the work to relax muscle, then those are called neutralizing antibodies. In the early batches of Botox, after its approval in 1989 through the mid-90s, there were high rates of antibodies being reported, particularly with cervical dystonia. Up to 10 to 20% of patients were developing neutralizing antibodies. The toxin was reformulated with lower protein load, and the antibody rate went way down to less than 5% and probably less than 1%. But as I mentioned, there's some recent provocative data suggesting the numbers may be higher. The two factors that are associated with the formation of antibodies are the total dose given at a session and potentially booster dosing. One of the reasons why we limit the total dose and we don't inject more than every 3 months. Okay, so another question. For spasticity, is efficacy the same for all the botulinum toxin A's? Well, you may remember from the evidence-based reviews I published in Neurology, we see that in the upper limb, the 3A types all have a level A. In the lower limb, only 2 of the 3 have a level A, and the third type A, which is botulinum or Xeomin, has not yet been FDA approved in the lower limb. More studies are going on now. So one has to look at the individual toxin and the individual studies. Now, another question, what are the injection sites for Botox? How do I inject and what is the dose? Well, that's a big question because the answer to the question is you inject the medicine where the patient needs it. So let's say somebody has hemifacial spasm, you inject around the eye. Let's say they have spasticity, you inject into those muscles that are spastic. Cervical dystonia into the neck. Cosmetic into the lines of the forehead. Depression, well, that's a whole interesting discussion, but the depression studies are also injecting into those similar forehead muscles that one does for cosmetic, and the theory as to why it may work in depression is a whole nother talk you'll have to invite me back for, although not my primary area of interest. Now, is the efficacy dose dependent is yet another question. Well, the answer is probably yes, but we know about efficacy based on the phase 3 placebo-controlled studies. And in fairness, we don't have excellent dose response studies. So many of the doses you'll find in the FDA labels are somewhat arbitrary based on the doses used in the studies. But in general, the bigger the muscle, the bigger the dose, because you need to relax or weaken that muscle to get effectiveness. Now, another question one asked is, what are examples of active functional gain? Now, you remember I separated passive gain from active gain in spasticity, for example. So passive gain, for example, would be somebody with a clenched fist like this in the nursing home, let's say with chronic stroke or traumatic brain injury or Alzheimer's. And as hard as you try, you can't get those fingers out of the palm. And that's a disability. By injecting botulinum toxin into the finger flexor muscles, which are in the forearm, you can get those muscles relaxed. And even if the patient can't actively use the hand, you can then get it open to clean it and much less painful. Now, again, there are patients with milder spasticity in whom they have difficulty extending the fingers. And then once you relax those muscles, they can actually extend and flex the fingers and get a functional grasp back and begin to use the hand in a more normal fashion. They can reach, they can grasp, perhaps even write. That's an active functional gain, higher level, harder to do, but in some patients can be done. Now, another question somebody asked is, in the lower limb, where do we inject? So again, it depends on where the disability is. Let's say you have that person with the equinovarus gait after a stroke. They're walking on their toes or on the side of the foot. Now we have to go back to our anatomy. Remember those nightmares of anatomy in the cadaver labs that all of you probably like to forget when we were trying to teach everybody about what muscles do what and what they look like when you dissect them? Well, we actually do cadaver labs now for our attendings who are injecting botulinum toxin. Why? Because you need to know where the muscles are and what they do so you can inject them properly. So if you think of the foot, what is the toe walker doing? They're activating the plantar flexors, the gastrocnemius and the soleus. Let's say they're walking on the side of the foot with a supinated, inverted foot. What muscle is that? That's the posterior tibialis. So in order to get the needle into those foot muscles, one needs to know anatomy, and we actually use ultrasound, electrical stimulation, and EMG to accurately target those muscles as well as possible. So let's see if there are any other questions that I can address here. There were a number of questions, I assume, from my psychiatry colleagues about the impact of antipsychotics on spasticity. And as I think many of you might know, probably better than me, some of the antipsychotics produce a phenomenon called tardive dyskinesia or tardive dystonia, which is a movement disorder that's different than spasticity, but of course can cause abnormal movements, dystonic movements, facial dyskinesia, and those types of dyskinesias can also be treated with botulinum toxin, particularly if they're localized. There were a number of questions about the use of Botox in depression. I've already alluded to that a number of times, obviously of great interest to the psychiatry community. I'm not sure to what extent the information has been disseminated, perhaps in some of your meetings, but suffice it to say that there are now emerging studies, mostly phase 2, and I believe there are now phase 3 placebo-controlled studies, particularly from Allergan with Botox, that are evaluating the efficacy and safety of Botox into the forehead muscles, particularly the procerus and the corrugator, which produces the so-called frown lines, and its impact on depression, with some very intriguing data. Again, not my area of expertise. I can't really speak much about the mechanism, but to my knowledge, it's not yet fully understood. There are theories, and let's just leave it that you will be seeing more to come on this in the future. Now, another question that comes up is migraines, somebody asked about. Now, you might know that there were a number of large phase 3, so-called preempt trials, again, using Botox. And those 2 phase 3 studies produced sufficient efficacy in chronic migraine. And these are individuals who have migraine headache 15 or more days per month, not the acute rare migraine, but the chronic migraineur. And the FDA has approved Botox again into forehead, side of the head, and back of the head muscles for the treatment of chronic migraine. Now, the dosing schedule every 3 months is what the labels indicate, and most insurers will reimburse only when given 3 months or longer apart. In our research studies, we're now beginning to do shorter injection intervals. We're measuring antibodies, but this is in research, not yet recommended for clinical purposes. So keep that 3-month period. Now, that can become challenging if a patient's getting multiple indications. Let's say the dermatologist is giving them wrinkle therapy, their headache doc is giving them migraine therapy, and their rehab doc is giving them spasticity therapy. You got 3 different docs giving 3 different indications, and they may be doing it at some random period, even within 3 months. And that gets very tricky. And the short approach or the message is to coordinate amongst the different physicians giving Botox so we know what our colleagues are doing and don't want to get into overdose problems. Now, another question is side effects. And what if you have a bad outcome, any way to manage? Well, obviously, every drug has side effects, potentially, some more serious than others. And botulinum toxin is no exception. The good news is that it's a pretty safe drug, particularly when used in low doses, such as in the forehead and some other indications. As you begin to get to higher doses, like we use in spasticity, the label actually goes to 400 units of Botox Reseamin and higher doses in some of the others. There have been cases, particularly children with cerebral palsy, getting high doses that have led to spread of the toxin through the body with respiratory failure and even death. And that has resulted in a black box warning in the toxins saying this drug can kill you. And every time I treat any patient, they sign a consent form, including the risk of death, which I think is important. Fortunately, it's rare, and most of the side effects are from local weakness that gets better within a couple of weeks. So I don't want to overstay my welcome. I've tried to address I think, many of the questions, probably not all of them, but I'll turn this back over to the moderator. And again, I can't thank you all in person and visit you in the coffee break, but I certainly hope that the message came through loud, if not clear, and maybe next time I'll be there in person. Thank you very much.